Next, I would like to invite Dr. MARIAN PAULY, ma'am. She will be talking on 10 tips on management of the ocular lid and adnexal surface trauma.
Good morning. Good morning, everybody. At the outset, let me thank Dr. Vanasri for giving me this opportunity. We know trauma is very, very important. So my topic is top 10 pearls in management of lid and adnexal trauma. So first pair, Dr. Vanasri has already discussed. One point which I would like to add is like if you're suspecting orbital injury or lid injury, always make sure there is no CNS injuries. There are instances while we are doing lid tear repair, patient develops seizures. So loss of consciousness, bleeding from the nose. This history has to be asked before you take up the patient, especially if you're working in a single specialty hospital. Multi-speciality, it is okay. Coming to the second pearl, so when you see a lid tear patient or any adnexal injury, suspected adnexal injury patient, always inspect the wound, clean the wound, and document the wound. So this is a case we just, if you see from external side, it's just a wound involving only the skin or muscle. But when you explore, the patient has got levator injury also. So this is irrigate and explore. That is a dictum: clean, explore, and then document. So that is very, very important in this case. So here also, if you see only this lid margin injury, but if you look very carefully, there is a small abrasion kind of thing near the medial end. When you explore, the patient is having a canalicular injury. So this happens very often, missing trivial injury. When you look at it, looks very small, but when you explore, this is a big injury. So after exploring, do not excise or discard any tissue and look for a presence of orbital fat. If there is orbital fat in the wound, that means the septum has been injured. So again, you explore to see any further levator injury or not. Then infraorbital as well as supraorbital anesthesia that shows there is a fracture. Then TT and all she has already mentioned. So coming to the pearl number 3, anesthesia. So we know litter is not an emergency. So anesthesia can be either local anesthesia, general anesthesia. Preferably local anesthesia include adrenaline also because it gives you hemostasis, or local anesthesia with the monitored anesthetic care. That is, we can give some sedation. That depends on the hospital which you are working and the pediatric or adult. So pearl number 4, coming to surgical principles, reapproximate the tissues as accurately as possible. Then close with minimal tension. If you put the wound under tension, it can gape. Then obliteration of the dead space. Don't just put 1 or 2 sutures and close. You have to do a layered, layered closure. Then good lighting and hemostasis finally. So I'll come to a few clinical scenarios. The one is superficial or deep laceration, but the margin is not involved. So in this simple closure or layered closure, you can use 6-0 Vicryl for the orbicularis and 6-0 silk, nylon, or plain gut for the skin. We prefer interrupted sutures. Running all sutures also can be done, but the problem is if there is a collection, you can get a hematoma. So if you are putting running sutures, give nice ice compresses so that oozing will not come, and try to get an everted skin edges so that you will get a very good scar. Should never close the septum. So I'll just tell you how to identify a septum in my later videos. Then undermine the edges if you think there is a minimal tension to the wound, and suture removal can be done in 5 to 7 days if you're using an non-absorbable sutures. Then coming to the role of glue, if it's a very small dry wound, you can use cyanoacrylate glue. The thing is, if you're putting cyanoacrylate glue, preferably don't put antibiotic ointment because ointment can aggravate easy. It will facilitate the easy disintegration of the glue and the wound can give. So but it should not be used in ragged wound, contaminated and crushed wounds. It is only for a dry, clean wound with no ooze. Then the role of taping. This is also again superficial, only skin deep. You can put a steri strip. You can put the steri strip so that the scar is going to be very good. Coming to the 6th pearl, that is lid margin tears. So triple suture technique, that is, one is meibomian gland orifice, 2 is gray line, and 3rd is lash line. So there are some important things: knots tied in the end anteriorly and long end of sutures anchored to the skin. I'll just go to the video. So local anesthesia is infiltrated. Then identify the meibomian gland orifice. Take sutures through that. This is a little very fast video. Wait. Then tarsus is sutured with vicryl. Then again go to the lid margin and suture the lash line with a non-absorbable. I use 6-0-ethylone. Then you finalize the orbicularis can be sutured with the vicryl and skin is also closed. And finally the wound is secured in the anterior part so that the sutures will not rub the cornea. So in pediatrics you can use 5-0 vicryl. So these are the few cases where lid margin is sutured, and if you do a good suture you will get a very good result. The main problem is if your alignment is not correct, you can get trichiasis that can create troubles later. Coming to the levator injury, it is suspected when there is fat in the wound or when the patient presents with ptosis. So in this left eye, he has got a ptosis, but when you look from the external side, there is no wound. But when you, in this case, you should evert the wound and evert the lid and see. So he had levator injury, but it improved by itself. So now, how will you identify the levator in a wound? So once you see a suspected levator, grasp that structure and ask the patient to look up and down. So the levator will move along with the up and down movement, whereas septum will not move. And when you grasp the septum, there you will feel a tension. That is, the septum is attached to the orbital rim, whereas the levator goes back to the orbit. So levator will move along with up and down movement, septum will not move. So this is the key point in how to identify the levator. It is repaired using 6-0 vicryl, and the levator is totally detached. You have to reattach to the tarsus again with either you can use vicryl or 6-0 proline, but before using proline, make sure it is levator, otherwise it can create other troubles. And septum should not get incorporated into the wound. So this is again another case. That's 29-year-old male had a fall from height, lid got hanged in the iron rod. So obviously when you look, the patient is not opening the lid. That is, there is a complete ptosis with a ragged lid wound. So don't consider this ptosis is due to mechanical edema. He had a total LPS avulsion. So when we explored, he had LPS avulsion as well as he had a lateral rectus injury also. So identifying levator injury is very, very important. It has got medical legal implications also. So this is his postoperative day 1, again total ptosis. At 3 months, he had residual ptosis, which improved 6 months, and later he underwent levator resection. So in traumatic ptosis, you will wait at least 6 months to 1 year before you correct the ptosis. Coming to the Pearl 8, that is total lid avulsion. So this is a case presented with a total lid avulsion following injury with the bicycle. So when the patient presents like this, if you can retrieve the lost tissue, it is always well and good. And ask the patient to keep the retrieved tissue in a gauze and soaked in gentamicin, and later it can be reconstructed. Reconstruction at the earliest is the most important thing, but most of the time 6 hours also it gives you good result because the lid is a very forgiving structure. Coming to Pearl 9, coming to the adnexal injuries, one is eyebrow. It can occur either in isolation or in continuation with the lid. The skin is thick. So always do 2-layer closure is a must. Deep closure should result in skin approximation. You can use 4-0 or 5-0 vicryl where it interrupted. Coming to the adnexal injuries, that is canaliculus. So in canalicular injury, the main challenge is to identify the distal end of the canaliculus. So I usually identify the distal end under microscope itself, even though various other methods like using fluorescein, using methylene blue has been described. So just look, this is the microscopy picture. So in this muscles, you can see it is more red, more pink, whereas mucosa is a uniform line structure. So in this structure is a canaliculus in this, and this is usually just underneath the conjunctiva. So coming to the video. So first dilate the punctum with the punctum dilator. Then I use mini monoca stent is inserted. So once the distal end is identified, your job is almost done. You can do syringing to confirm whether the patency and whether you are on the correct path. Then the tube is inserted, that is mini-Malacca stent. Then the peritubal structures, you can put anteriorly and posteriorly structures closed with the 7O vicryl, and the skin is closed in the routine fashion. Now coming to canthal tendon injuries, that is medial canthal tendon and the lateral canthal tendon. This is very, very important. If you don't close the tendon, you can get either ectropion or lid retraction. Patient might not be happy. If only the superficial laceration, you can just directly close. This is very important, especially in canalicular injury. You can get an associated medial canthal tendon injury. So, if the posterior limb of the medial canthal tendon is injured, you have to reattach to the periosteum. You can use 40 vicryl, or you can use proline also. The problem with the proline is the knot should be buried, otherwise it can get extruded later. Post-op care, can patch for 1 day or 6 hours, start systemic and topical antibiotics, ice compresses, do a little bit of head elevation so that edema will be less, and scar massage after suture removal. If it is parallel to the lid crease, then it is okay. Scar might not be a problem, but if it is vertical to the lid crease, do a scar massage. And there are some various anti-scar creams are also available if the patient is very much concerned about the scar. Most of the time, the scar will settle without any specific scar treatment. Coming to the final pearl number 10, that is management of sequelae. If you do a very good lid tear repair, sequelae are very minimal, but there are some sequelae which is inevitable. So you can get notching, the lag of thalamus, ectropion, entropion, canalicular block, and canthal malpositions. So that all, this is 1-2 months post RTA. She had an extensive skin loss. So she had an ectropion, which we have corrected later with a full thickness skin graft, because this ectropion was not settling even with anti-scar treatment. So waited for 6 months, and then we did ectropion correction. Similarly, this is lag of thalamus with the corneal ulcer due to the anterior lamellar deficiency and the lid notch. So in this case, we can't wait because there is a functional deficit in this. So the moment patient presented to us like this, we corrected the lag of thalamus with the anterior lamellar. Anterior lamella is strengthened with, augmented with skin graft, and the lag of thalamus has improved. So these are my top 10 pearls. So excellent functional and cosmetic results are possible with planned and meticulous surgical technique. Thank you.
Thank you so much, ma'am. That was a wonderful 10 points that we could take. Ma'am, please come on dais. Dr. Marian Pauly, ma'am, is a senior oculoplasty consultant at Giridhara Institute. And thank you so much, ma'am.